Dr. Aishwarya Joshi will be talking on DYI suprachoroidal needle.
Dr. Prithvi can please come on this side. Is Dr. Prithvi there?
Good afternoon, I'm Dr. Aishwarya, and today I'll be talking about a model I'll start it. A model of suprachoroidal needle which we have designed. It is a DIY technique and it is very easily available. The materials are very easily available and it can be used by anyone. And now with the advent of suprachoroidal injection drugs in the form of tyrosine kinase inhibitors, triamcinolone acetonide, and even gene therapy, this will be of utmost importance to learn this technique.
Done in 10 patients to analyze the technique and safety of suprachoroidal injection by our own DIY model of suprachoroidal needle. The materials required are 26 gauge needle, 22 gauge vein flann IV cannula, 15 number blade with a Bart Parker handle. As shown here, the length of a 26 gauge needle is 11.5 millimeters. Keeping this in mind, 22 gauge vein flann IV cannula is measured for 9 millimeter length and is cut. Care should be taken for the ends to not rebound off the sterile area. Then we assemble the 9 millimeter long cut part of the cannula over a 26 gauge needle in such a manner that it leaves 1800 micrometers of the needle end exposed. Technique, 2 suprachoroidal injection needles can be made from just one cannula. In this patient, we planned intravitreal injection of anti-VEGF with suprachoroidal triamcinolone acetate injection in the same sitting. At 3.5 millimeters from the limbus at pars plana zone, intravitreal anti-VEGF was delivered as usual. An AC tap was done for decreasing the eye pressure and allowing the injection in suprachoroidal space as much as 200 microliters as shown here. Entry should be made at 45 degrees for 1800 micrometers of the exposed needle to pierce the sclera and sit in the suprachoroidal space snugly. After gently removing the needle, there was no regurgitation of the drug. This AIOC captures the suprachoroidal space in its usual state, wherein this picture was taken post-suprachoroidal injection, which confirms the presence of the drug in the right space. With our design of suprachoroidal injection, we titrated the length of the needle in such a way that there is no inadvertent entry into the vitreous cavity. This was proved in all of our 10 cases. The most common complication noted was a subconjunctival hemorrhage in 3 patients. With newer upcoming treatment modalities requiring suprachoroidal drug delivery, such as gene and cell replacement therapy, we contend our model to be minimally invasive, cost-effective, accessible, and an overall efficient in-office procedure. This being the solution to the expense and patent issues associated with currently available alternatives for suprachoroidal mode of drug delivery.
No, the commercially available needle film clear side is 900 micron and 1100 micron for the thicker sclera.
Yes, sir.
The basic difference is if you see the opening at the tip of the needle is quite, it's longer in case of these needles.
Yes, sir.
Compared to what is available in the clear side needle. So that gives a precise delivery, number one.
Yes.
And number two, there were two RCTs. One is sapphire, the other one is topaz.
Okay.
Both have been abandoned, saying that there is no difference between intravitreal, the anti-VEGF versus a suprachoroidal injection of steroid. So they halfway through, after seeing the result, they abandoned. So are you still giving this suprachoroidal, the steroids for vein occlusions and the diabetics? Because there are no evidence for that. It has been abandoned already.
Yes, sir. So from our pilot study, we've seen that the incidence of steroid-induced glaucoma is lesser. Plus the fact that we are not giving it inside the eyeball, it induces, the chance of inducing a cataract is way less. And in eyes which are vitrectomized, eyes which don't have a lens, aphakic eyes, in them you can easily give this. There will be no migration of the drug into the anterior chamber as well. And it forms a nice depot which is easily, the bioavailability is much better considering that it is in that compartment. So that is why it is better, and there have been studies on this. There is HULK trial for diabetic macular edema, then there is Peachtree trial for non-infective uveitis. So for all these, for RVOs also there is Tanzanite trial. So they have given, but they have used the conventional needle which is a little expensive, it's 650 rupees. And here you can make 2 needles in less than 100 rupees.
But a similar model already available, right?
Yes, sir. Others have used it, but our technique is such that we keep the end which goes inside a little longer so that we can give a valved entry and there is lesser regurgitation and the needle sits snugly inside the suprachoroidal space. So the drug nicely goes in, as in the bevel is facing the choroid. So we are not, the chances of puncturing the choroid is way less.